Well, first of all, we need to be confident with the technology, because, and that is, you are absolutely right. To be confident with the technology, we have a lot of offering today. Different technology, different set, trifocal, ADOF, the old bifocal, monofocal that change their mind and seems work a little bit for intermediate. So there is a lot of confusion. So first of all, we need to remember for which purpose every technology should be submitted and approved. And then, so we have the starting point, different characteristic of the IOL. This IOL, due to the pinhole concept, is something that we need to recognize that should be implanted mainly only in one eye. And that is the first difficulties to accept, because in the surgeon mentality, we have to apply the same technology in both eyes. Because if we create a difference, this is a difference that also the patient feel, and he asks himself, oh, why one eye is working in one way and why the other eye is different? So probably there is something wrong in one of the two eyes. So, and because the surgeon, before adopting a technology, need to be, to realize the quality of the technology, the efficiency of the technology, and he needs to find the motivation about to start. When he started, this is the most important focal point. He get personal experience, and after his personal experience, he decide what should be the best patient to get in, why is wider, because the results are more effective if compared with the traditional technology that is adopting. So naturally, as always, it takes a little bit of time. It takes the volunteer to go deeper in the technology, to study the technology, to study the patient reaction, and to be supported by the fact. Now, when we have to manage aberration, or mild irregular cornea, or RK outcomes, this is the only best solution till now. So I think that this could be a starting point, because when you are supported in the difficult cases where you have no other alternative, and because the results are a little bit weak, I think that this could be a great push to be confident with the technology, to be confident and manage some little weak point, as I told you before, and to start. In my opinion, this is not a bilateral implant. Why? Because naturally, the IOL is based on the mask that create a pinhole effect. But if you implanted both, you have a reduction of the contrast sensitivity. And so I have experience in 5 patients where I adopted the technology 3 years ago bilaterally, and they are happy because naturally the improvement for near is perfect over their expectation. But at the sunset, like mild myope, they have a loss of contrast sensitivity, and so they say, well, this is my little bit tricky time to drive the car. And one more time, driving the car is an opportunity that we can't underestimate, because it is a scale coming from our patient to judge your operation, to judge your result, because the patient fear to see in a different way, but they do not want to be penalized at all when they are driving the car. Well, I have dedicated 10 years to this topic, and was my most lucky experience. Why? because I have not really confident information, because if we are speaking to this evolution is a 16-year evolution. Seems this, but it's not. 16 years are a lot. In this 16 years, we face different solutions, different affirmation. This is the best. This is working well. This is the given solution. And was not, because the technology needed evolution. You know that now we are facing 10 generations of phaco machine. And I have experienced the first one and was a nightmare. But naturally, wonderful result, but in proportion. So in this matter, we need to understand that also small percentage of an happy patient kill the technology and avoid the spreading of the technology. So I started to learn the base concept. I looked what technology, one more time, was submitted and for what was approved. Trifocal technology is the only technology submitted and approved for distance, intermediate, and near vision. For example, EDOF technology was submitted and approved for distance and intermediate. Stop, not for near, but they claim that near vision with EDOF is fantastic. So there is something that needed to be focused better. And naturally, you can focus this from reaction and from the patient. Patient is the most important resource to drive your decision, because looking at the patient, hearing the patient, I understood how was important tear film quality. For me, tear film quality was something stupid, something that I have no interest, something that I do not want manage for any time. It's something that patient, okay, you have your tear film, meibomian gland dysfunction, dry eye difficulties. It's not my problem. I know that I can manage this with everything. I can change 100 drops and nothing changed. So please go refer to my colleagues that dedicate this for his life, and they will support you, because I didn't believe in that. But in looking at the result of the biometry, because one more time, the key point is perfect biometry. Now we have the advanced machine. The technology is advanced. We have 5 generations of biometry. Now we have an upgrade by IOL Master TK. What does it mean? That it takes a precise 1 micron precision measurement of the anterior and the posterior corner. We didn't know nothing about the posterior corner before, but if the goal is to be within half diopter of astigmatism after cataract surgery, biometry is mandatory, and this is my goal. We perform more time the biometry to be sure, but we have learned to detect immediately if the patient needs improvement of a tear film. Improvement means, first of all, detect it, make a treatment. I use and I am adopting LipiFlu, and then give therapy, because to obtain the perfect surface of the cornea for the right measurement, you need almost 3 weeks or drops after the treatment to make the perfect situation. And so that is something that is not accepted. Why? Fix at my organization is a drama. Normally, I am a private organization, very flexible, fast, professional. I face with my patient on Friday, and exceptionally, I can perform the surgery on Monday. But now, I see the patient on Friday, I make the diagnosis that need treatment, and I need to postpone everything just organized of 40 days. Because I need to perform the treatment, to perform LipiFlu, make the drop for the treatment, look at the result with 2 more consultations to understand if the quality of tear film is improved or not, and if the machine certify to me, okay, look, now the film of the cornea quality is perfect and my result is 100% effective. Because if not, I start behind because we have experienced that making the measurement with the IOL master 2 minutes after, we can also find 1.5 diopter of different astigmatism and 30 degrees of the rotation of the axis. If I follow this information, I fall. And my patient come back and watch shot me.